Now, persistent or recurrent hyperparathyroidism usually can occur in men-1 hyperparathyroidism, as I've told, about 20 to 60% at 10 years. And this is because there is a failure to locate either one or more supernumerary glands, or there is an ectopic gland. So sometimes you can get recurrent hyperparathyroidism because of hyperplasia of the remnant that we have left behind, or that we have auto-transplanted in the forearm. And for a patient with persistent hyperparathyroidism, we do a repeat biochemical evaluation to establish the diagnosis. We usually have to do re-surgery, so we do a vocal cord analysis and look at the previous surgical records, and we can do a relocalization imaging with two imaging modalities. So we can either use a system, maybe ultrasound, MRI, 4D CT, or venous sampling. And eventually, for recurrent hyperparathyroidism, these patients require repeat surgery. So while doing a surgery for recurrent hyperparathyroidism in men-1 disease, it's important to remember the embryological variants, embryological locations where you can have ectopic parathyroid gland. So usually in inferior parathyroid gland, you'll have to do a complete removal with removal of the thymus, whereas a superior parathyroid gland will require excision, and it will also require exploration of the other spaces such as retroesophageal space, upper posterior mediastinum, carotid sheath, carotid bifurcation, the thyroid and the pharyngeal musculature. If you have a mediastinal ectopic parathyroid gland, then again that excision will require a video assisted thoracoscopic surgery or a sternotomy or a thoracotomy. And sometimes you can have a recurrent hyperparathyroidism because of recurrence or hyperplasia of the graft, and usually these graft related recurrences can be explored under local anesthesia and can be removed.